So welcome. Thank you for attending today's health talk. We're going to get started here as our guests join in. I'm Deborah Williams. I'm a clinical assistant professor here at the College of Health Solutions, and I'd like to thank you for joining our Health Talks webinar today. And it's brought to you by the College of Health Solutions at ASU. Our college addresses the challenges facing people and communities to stay healthy, to improve their health, and to manage chronic disease. And these health talks are one way that we serve the community with timely and relevant educational content, as well as providing continuing education at no cost. A few housekeeping items before we proceed. First, as you may have heard, the session is being recorded and it will be posted on our website, which is asuhealthtalks.com. After all of our panelists present, I will moderate a Q&A session. So please submit your questions using the Q&A feature that you see at the bottom, not the chat box. And then finally, you're going to receive a brief survey asking for your input about today's webinar. If you've asked for CEUs, this must be completed in order to receive that credit. If you didn't apply for CEUs, we would still really appreciate your feedback to improve our series. So with that said, today's topic is Alzheimer's disease, a discussion of context, communication, care, and COVID-19. And joining me today are Elizabeth Truba. She is an assistant clinical professor in the College of Health Solutions, and she has a long career in working with adults as an SLP for trauma hospitals and stroke centers here in the Phoenix metro area, expanding even further to a variety of clinical experiences for ASU's speech and language students. She will be followed by Dr. Jean Brown, who is a clinical professor of speech and language pathology at the College of Health Solutions, and her research ranges from classroom-based preschool communication programming and family-centered early intervention services to multicultural concerns and issues. And lastly, Dr. David Kuhn is joining us. He's Associate Dean of Research Initiatives, Support, and Engagement, as well as a professor in the Edson College of Nursing and Health Innovation at ASU. He also leads the ASU Center for Innovation and Healthy and Resilient Aging and is well known for his research on Alzheimer's and aging. So with that said, and those introductions, we'll get started. And Zachary will share the screen.
All right. Zach, can you flip to the first slide? I'm actually going to kick us off and just to provide a little context with a few facts and figures related to Alzheimer's disease and related dementias. So in the US, of the 330 plus million people that we have in our country, 6.2 million are age 65 and older that are actually living with Alzheimer's disease or related dementia right now. And because age is the greatest risk factor and we are an aging society, it's projected to rise to nearly 13.8 million by 2060. Most of us want to age at home, and so it's not surprising that well over 70% of people with dementia live at home. And it continues to rise with these numbers, currently the sixth leading cause of death. That may go up. Let's switch context and think about in Arizona. In 2020, 1 in 4 people were age 65 or older. The fastest group were among those that are sometimes considered to be the oldest old if you're over 75, and that's the fastest growing group. We are number 1. By 2025, more than 200,000 Arizonans will have Alzheimer's disease or related dementia, and that's the largest percentage increase between now and 2025. It is currently the 5th leading cause of death here in our state. Zach? So I want to just step back for a minute. And for those folks that are less familiar, dementia, and many times it is used interchangeably with Alzheimer's disease. However, dementia is a group of symptoms. It's a syndrome that is associated with ongoing decline in our cognitive functioning. The hallmark of which is changes in memory and memory loss, But it can range from a variety of things along with that, like thinking speed. I joke with my graduate students and research tech folks who are age 25, because after 25 on average, it's downhill. We don't process as sharply as we did before that. But it can involve language, which Elizabeth is going to spend time in, involve mood changes, and the like. But the most common type of dementia is Alzheimer's disease. It's bolded. I don't know if you can see that on the slide, but then there are others listed here like vascular dementia, FTD, and Lewy bodies dementia. Zach? So to also provide some context and sort of bring the level of sometimes stress that some of us who are aging think about, it's important to think about what's normal. What are those normal changes with aging? And also what's normal for me? As my sister always reminds me, you know, I've never had as great a memory as you do, David. So I'm going to set my bar at a different starting point than yours does. So if you start really on the right side and look at normal aging, it's not unusual that as we grow older, we occasionally forget words, the date, or some kind of appointment or task. It slips our mind, or we may have more difficulty paying attention to something, getting more distracted, and multitasking. Although many people might debate that multitasking is actually a myth, to really concentrate on too many things at once. But it might be that it used to be that you were able to listen to music and handle certain kinds of things, and it gets a little more challenging. Now, that's also the case with mild cognitive impairment, which is in the second column, or Alzheimer's disease. So all three of those sort of have that in common. But as we go down the list, as you start to develop mild cognitive impairment, and a proportion of those people go on to develop Alzheimer's disease who get diagnosed with MCI, and that's starting to begin to forget more important information, which is often recalled more easily. For example, your good friend's name or a recent event and what happened there. You may, in comparison to your same age peers, have more trouble with word finding and start to struggle with more complex planning tasks like balancing your checkbook. But even taking those, folks with Alzheimer's disease start to have even more problems with basic activities of daily living as the disease progresses, and increasing trouble speaking with, carrying on a train of thought, etc., with folks that they're communicating with, and in terms of their language production and receipt. And with that, I'll turn it back over to Elizabeth, who's really going to delve in more into this communication area.
All right, thank you, David. And that's a perfect transition into communication. So we will see a lot of changes with expressive language with people who have Alzheimer's or related dementias. So that can look a lot of different ways, and it will obviously continue to progress and worsen over time. So this could be someone who's having a hard time finding the right word in conversation. This may look like they just need additional time to put a thought or idea together. It may be someone who's using a word substitution. So using the wrong word, maybe you're sitting at dinner and they really want you to pass the pepper, but they keep saying to pass the pencil. And even if everyone else can pick up the context, that can be very frustrating for the individual who's trying to communicate. We may see an empty repetition of other people's words. So maybe you say something and they're just repeating that word over and over, but it doesn't quite mean anything, or they're not intending to use that word or even say it. There's a general lack of meaningful content in conversation. So they might be speaking for perhaps a very long period of time, but they have a very difficult time conveying their intended message. So it comes off as a little bit empty of content. All of this will lead to a decreased spontaneous conversation, right? So someone who's having all these difficulties expressing themselves will likely start to turn inward and not try as much or initiate as much conversation. Not directly related to language, but speech concerns will show up too, where that person is maybe harder to understand because of imprecise articulation. You can go to the next slide, thank you. So receptive language, this is how well we are understanding the language input that we're getting. So this could be understanding of someone's auditory input, so how well you understand what someone's saying to you. And it can also show up in reading as well, so having a hard time with reading comprehension. So overall, this would be an impaired understanding of language. We'll see this very often in the beginning as just someone having a hard time following directions. So especially if you're giving a more complex direction, a direction that includes more than one step is going to be harder for this individual to process. And then that relates to just an overall difficulty of comprehending complex language. So if you were telling someone, I'll be at your house to pick you up at 10, that's probably enough information instead of saying, I'll be at your house tomorrow at 10. I'm actually borrowing Jim's car because mine's in the shop. I'm going to stop for coffee first, and then I'll probably grab a newspaper and be there to see you. By the time your full message is out, they can't quite comprehend all of that sometimes because they're still decoding the first part of your message. And we'll see that too in answers to questions. So this may often appear in yes or no questions. So oftentimes an individual with Alzheimer's or related dementia, they understand still the social aspects of communication. So they understand a question is being asked. They might understand that you're waiting for a yes or no response, but they still don't quite understand the message. So they may give you a quick response, but it might not be what they actually feel to be true. All right, and then we will also see changes in cognition. So as we know, with Alzheimer's and related dementias, impaired short-term memory is going to obviously stand out as an impact on communication and cognition. But we'll also see things like poor topic maintenance in conversation. So this can be related to language deficits or cognition. So either they can't understand the message that you're giving to them, so they're having trouble participating. They can't quite convey their message, so they're having trouble participating, or their attention span is impaired, so they're not able to keep up with the conversation, especially in a group setting where the conversation tends to move pretty quick. We'll also see things like disorientation, so that person may not know where they are or remember even biographical information, so about where they were born or what year they were born, the season of the year, things like that. And we will see a loss of initiative. So David had mentioned, the effects on activities of daily living. We will see that a lot with this cognitive impairment. So that person may not be able to get up out of bed and initiate their whole daily routine of getting dressed and brushing teeth and making breakfast because of these changes to cognition. So we'll see an overall decline in many cognitive areas. So organization, decision-making, other executive function changes. So, we'll see impairment with flexible thinking, with self-control. It'll be very hard for these individuals to focus. All right, next slide. Thank you. All right, so I think when we think about these changes, all of these changes that people are experiencing related to language and cognition, I want us to really think about the impact, the big picture of that. What does that mean? So there was a study in 2019 that showed 60-year-olds who visited with friends almost daily were 12% less likely to develop dementia than those who saw friends one or two friends every few months. The results of this study too showed that this was more related to contact with friends, as contact with friends was more cognitively stimulating oftentimes than those communication interactions that people had with family or relatives. The study aimed to find causes of dementia, but they really found that the social isolation was an early consequence. So as people are experiencing these changes to their language and communication and cognition, they really aren't using it as much. So they have a lack of communication opportunities. They may not be seeking out social engagement or conversation with friends anymore because they can't, because they're experiencing so much difficulty, or because of the embarrassment or shame that they're starting to feel by noticing that they're having these issues. All right, and then once we also layer on COVID to all of this, we really have to think about how this global pandemic has exacerbated all of these impacts. So Obviously, we've all seen an increase in social isolation, but this has really, really affected this group of people. People that are living in assisted care facilities were cut off from socialization with family and friends. A lot of the policies obviously shifted to minimal to no visitation in these facilities. People that are living in their own homes may have more access to socialization, but many times they weren't able to leave their home for a long period of time because of the restrictions of COVID. We saw a loss, a slowdown or a complete stop to a lot of different support groups and care organizations like Visiting Angels, or perhaps if that person had, a neighbor or a friend from church that was stopping by frequently to drop off meals or to say hi, all of that came to a pretty sudden end. When we think about personal protective equipment, so things like masks, even eye shields, that has increased a lot of communication difficulties. So if someone is already having a hard time understanding language and now they're being completely blocked from seeing their communication partner's mouth or facial features, it's just adding to the cognitive demand on them just to communicate in conversation. And then this group of people also have a lot of barriers to technology. So there may just be, obviously with COVID, a lot of our communication shifted online, right? So it's a more social media and FaceTime, teletherapy appointments for healthcare. So for an older person who doesn't have that skill already perfected, that was a really hard shift. So they may not have been able to participate in any of those ways to communicate. And then we have to think about lack of access too. So does that person even have a smartphone? Do they have a tablet? Do they have Wi-Fi at their house? Can they afford any of those things? So that really put an extra layer of difficulty on communication for this population. So the last thing that I wanted to talk about too is the importance of screenings and prevention. So in 2018, the Alzheimer's Association put out a survey, and on that survey, 82% of seniors felt like it was very important to have their cognition routinely checked. And then they saw that about 16% of that group did say that they were routinely checked. So there's kind of a disconnect there. Screeners really are designed to be a quick tool for healthcare providers to identify areas of concern. So a screener is not going to be a way to diagnose any kind of dementia, but it can open up the discussion between that individual and the healthcare provider, and even with their family too, about areas that maybe need to be assessed a little bit further. So oftentimes a screener, if anything is noticed, is accompanied by a diagnostic follow-up and care plan. So the other big important reason, or the big advantage to doing screeners, is that we also have a baseline of someone's skills. So like David mentioned, you kind of want to know your own personal baseline. Perhaps memory has never been a strong suit for you. So if you're seeing a healthcare provider that notices a memory deficit, we want to know too, what is your normal? Have we seen a decline? So by doing a screener, we can start to, or doing a regular screener, we can really start to see changes. And again, keep this conversation at the forefront of everyone's minds. And then even if it doesn't lead to a Alzheimer's or dementia diagnosis, it can initiate changes to that person's environment, to the level of assistance that they're getting, to caregiver training, just to give that person more support in their home as they need it. And next slide. The other things we need to consider with screeners are just the overall limitations. So there are a lot of inherent biases in a lot of the screening tools that are used. The mini mental state exam is a very common screener that's used. And it actually has a 42% false positive rate for cognitive impairment versus for African Americans versus a 6% false positive rate among the white population. So we know that a lot of these screeners have inherent biases in them. It can be related to race. It can also be related to age, socioeconomic status, education, and very importantly, literacy. So not necessarily the quantity of education that person has had, but the quality is very important. So, and like I mentioned before, the screeners are important to have because they can give us a glimpse into someone's skills and again, how they're progressing over time. So if someone has access to a screener, they'll have more access to ongoing support. So we need to really think about the populations that don't necessarily have that access. We'll go to my next. And Jean is going to talk a little bit more about delayed diagnosis and inadequate treatment in specific populations, but I did want to introduce some of the concerns that research has highlighted in relation to the underdiagnosis of dementia. So oftentimes people who are older, who have fewer years of education, unmarried, people that are attending medical visits alone. The other spots I wanted to highlight are people with fewer functional deficits. So someone that can kind of get by, even though they're having changes with their memory, their language, their cognition, they can usually not necessarily fake it, but during a medical visit, during a visit with their provider, or even during a short visit with their family, they can make it seem that they're doing a lot better than they are. And a lot of times they're being skipped to receive services. And then also to highlight again with COVID, just this limited access or ability to use telehealth. So people that don't have the device, that don't have Wi-Fi, that don't have the insurance, that don't have access to telehealth or healthcare services can be at a very high risk of being missed in this diagnosis process. And with that, I will flip it over to Jean.
Thank you, Liz. I wanted to start out with this very stark statistic here. By 2030, Latinos and African Americans will make up nearly 40% of the 8.4 million American families affected by Alzheimer's disease. We know that we have disparity in healthcare, and it is more stark in this population, I believe, than any of the others. And so that's what I'm going to be talking about. Next slide, please. And I'm going to start by telling two personal stories. One, the lady on the left is not my aunt, but I did have an aunt. Her name was Rug, and I grew up with her. And she was a twin, and she has some intellectual disabilities. And when she was a senior, she developed Alzheimer's. And I was in my graduate program in speech language pathology and knew a little bit, I guess too much, but enough to share with my mother that this actually was a disease process. And I watched what happened with that. My mother didn't seek outside help for my aunt. She stayed at home. She took care of herself. She had the burden of two elders because Rug was a twin, as I said, to my grandmother. So at the same time, she had these two elders at home, one who was intellectually challenged and had Alzheimer's, and then my grandmother who seemed to be stable with her memory. She could remember anything just like a sieve, but her body was deteriorating. And the care, untypical like some whites perhaps, there was no nursing home involved. My mother took on all the care for those two women herself, and just with suggestions for myself. A more recent one is MLL, who's a friend right now. I was seeing her, just as Liz said, once a month in a group of elders. We got together to do some crocheting. And over the last 13 months, I've watched her just slip into dementia. She is not being able to swallow. She doesn't remember my name. She remembers who I am. And when I go to visit her, she knows who I am. We do some praying because she's a Hispanic woman and she remembers all of the prayers, but my name, I still haven't heard it. And it was very interesting to see how quickly that happened because of COVID. As long as the friends were coming over to her home and visiting her, she was doing great. She started to fall as well. So a couple of weeks ago, she fell and she hit her head and she has a lot of bruising. Her speech is imprecise. You can't understand what she says. And so it's a matter of changing food. Her son is involved, but he is very hesitant to say, this is a time we need to put mom maybe in a home or whatever. The closest friend to her in her neighborhood is also elderly, and she's 84, and she's coming over to help her. I tried to get all these ladies on Zoom so that we could meet up and have some chats, but as Liz stated, technology prevented that from happening. So there are two people that I know. I know that there are changes in their lives, and a lot of those things are dictated not only by their race and ethnicity, but by their language and by other cultural factors. And that will be the bulk of what I'd like to discuss with you today, and how we can give these people, like my friends, my aunt, and MLL, access to the healthcare system that is so readily available to other people. Next slide, please. So delayed diagnosis and inadequate treatment, why does that occur? Next slide. A lot of people believe that it's stigma, a misunderstanding, and weak linkages to our nation's healthcare system. They're leading to significant disparities in Alzheimer's and dementia diagnosis rates, access to treatment, quality care, clinical research, and trial participation rates among Latinos and African Americans. So things are there for these groups to access, but how do you get them involved? How do you get them to those trials? And even in our research project, it's a broken system, and there is a lot of stigma attached. One of them is that perhaps we don't know how to take care of our family member, and we don't want other people to know. Next slide. So there are a lot of reasons. One, the first is biological, genetics. Maybe these groups are prone more to Alzheimer's and other related diseases because of their health, hypertension, diabetes, heart disease, strokes, and hearing loss, and lifestyle choices such as smoking or drinking. And a lot of these I have found in African American communities are due to stress and stressors of just daily life and making it. Next slide, please. So we can look at cultural things too. A lot of the things that we see on the surface of culture, we co-opt. People's food, their language, their festivals and things that they do, their music. We can all do a high five. That's okay. We all become Irish, on March 17th. On May 5th, we will all be Hispanic, and we'll be celebrating those things that we value. But there are a lot of things below the surface that go unrecognized. And it's just how people communicate and the rules of communications, their notions of friendship, and how they even interact and talk to professionals, and their attitudes toward health. We may see dementia as a disease, and that's something that we can quantify. But for some of these groups, it's an illness, and it's how they personally perceived it. When my aunt I helped her to diagnose her with Alzheimer's. It was more my mother thought, well, she's just entering her second childhood. That's what happens to us all. This isn't a disease. This isn't a disease. It's just naturally what happens. So we need to go deeper with these cultures and try to figure out what it is and how they perceive disease and illness. And there is a difference. Next slide. So this is one explanatory model that was put forth by Gilmore and Manley in 2008. So we can start with race and ethnicity, but it's geographic exposures, immigration, socioeconomic status, discrimination, which we're all involved in now because of just the temperature and what we're going through in our country, group resources, group ties, group identity, but more on the individual level, material conditions, psychological stressors, as Liz talked about, cognitive engagement, test-taking skills. Not all of us take those tests that are put out there the same way. We don't approach them the same way. Cognitive function, impairment, and change. And then things that are more proximal, physical health, health behaviors, and access to medical care. You probably have been reading a lot about even some of these cultures, African Americans and Hispanic Latino populations. They're not taking COVID vaccines because they understand those things differently, even though it may be available. Next slide. So one of the ways that people have tried to explain it as well was Kleiman, who had a section in the book called "The Spirit Catches You and You Fall Down." And they came up with these 8 questions, and we need to ask these questions when we're involved with any group of people because they may not perceive or define it the same as us. What do you call your problem? What name do you give it? My mother gave it second childhood. So how do they name it? Does it even exist if they don't have a name for it? What do you think has caused it? Why did it start? And when did it start? What does your sickness do to your body? How does it work inside of you? Next slide. How severe is it? Will it get better soon or take longer? Well, with my mother, she thought that my aunt would just go through this process and she would just die and she didn't need to do any intervention. What do you fear most about your sickness? All of us have fears, and if you talk to people in detail, they'll usually tell you. Most of the times it might be dying alone and not having anybody there with you to assist you. Leaving your home, I think, with my friend MLL, she's afraid of having to leave her home. What are the chief problems your sickness has caused for you personally, for your family, for your work? What kind of treatment do you think you should receive? What are the most important results you hope to receive from the treatment? If we ask these questions, I think we get a better ethnographic, a qualitative difference about disease and illness, particularly from multicultural groups. Next slide. So these are some of the reasons why this system is broken. Systemic racism, microaggressions, contract versus contact, which is one of my favorite ones. We all have a contract to meet the needs of these populations, but usually we don't see a doctor or a speech language pathologist until we are in a professional situation. And some people have spoken about this as the professional arena, the popular arena, and the folk arena. And most things take place in decisions in the popular arena. And then maybe we'll go to a solution. My grandmother had a solution for everything. You could go out in the backyard, you can make a tea, you can make things better before you went to the doctor. So how do we get in these people in so that we can see them? And then hierarchy versus collaboration. Do we talk to these people in a way where we're talking down to them, or are we working with them? Or are we working with the primary caregiver, or are we working with the family as a unit? And with some groups, multicultural groups, you need to work with the family and not just with the primary caregiver. If you were working with my aunt and my mother, you needed to work with my mother, but you also needed to work with me. And some of the things I think that we often forget is the road of fatalism. This is just what's going to happen. A lot of these groups believe that this is just it. Why do anything about it? Language and communication styles. In my group, African American, which I identify with, my mother would come to your office and probably be speaking Black dialect. You might not understand her language style or her nonverbal communication. And often when that's not understood, that goes to silence and passive aggression. In the case of MLL, she's a Spanish speaker, or perhaps you don't understand the Spanish and the idioms or whatever is going on in that culture. And a lot of times people just get angry, and just because they say yes doesn't mean that they're going to follow what you say. And all that leads to a big area of mistrust. You may prescribe the medication, they're not going to take it. Same thing could be said for what's going on with the COVID vaccine. Next slide. And so another way that we can help these communities, I think, is becoming cultural brokers. I think that is an area of research that we're just not looking at very closely. We need people to walk with people on their journeys and look at the systems and cultures that are affecting them. One of the ways is to look at the things that they have no control over. Some people have stated this as being the ABC dimensions. You can look at a person's gender, their race, their social economic status, their education, and their life experiences. Those are things that perhaps they don't have any control over, sexual orientation, for instance. And then there are things that they can change. I've been educated. My mother was not. So that puts me in a different group. I moved from Alabama to Arizona. So it's a different culture. And then there are things where people were born. If you were born in the 60s or the 40s, then historical situations make things different for you. So you have to look at all of those factors. Then you have to identify the problems, the needs of the families, and the barriers to access and how to utilize the services. Then there needs to be a broker there to help with the educating, the connecting, the networking, the mediating, and negotiation. And then you have to continuously evaluate these outcomes, establish connections, meet the family's needs, increase the family's confidence to access the services, improve cultural awareness. And if something fails, find out where the breakdown is and go back and repeat the steps until you get the outcome that you want. Next slide, please. So I'm going to hand it over to David now, who's going to talk a little bit more about caregivers and their plight.
Thank you, Jean. So I want to start with this quote. It's one of my favorite quotes, and you'll see that I think it resonates with almost everyone. There are four kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. And of course, the reality of all of this is that many of us will play multiple roles across our lifespan in terms of this. And that quote is from our former First Lady, Rosalind Carter, and who established the Rosalind Carter Institute a couple of decades ago, dedicated to family caregiving work. Zach? So in thinking about the context too, I guess sometimes we really have to step back and really give a hand to our family caregivers. And this is so critically important. I'm fortunate enough to work with family caregivers almost on the daily in different ways. But just to break it down in some ways, another way that people don't think of is that in 2020, over 11.2 million Americans provided 15.3 billion hours of unpaid care to people with dementia. Okay, so we need to think about that and step back and realize if we took that and paid people, even the kind of very, unfortunately, small wage that we give to direct care workers in our society, that would be an estimated value of almost $257 billion. That's roughly half the net value of Walmart's total revenue of $524 billion last year. So we need to keep in mind, and I always talk about giving caregivers a hand, and I mean that in multiple ways, but in this case, that if we didn't have family caregivers, our entire long-term supportive services network would fall apart. If we had to pay for it, that's what we would need to be paying for as a society. Next slide. So I also want people to just think, sometimes I have someone say to me, well, isn't this just what my grandmother did for my grandfather? Well, maybe, but maybe you didn't exactly know what was going on in terms of her responsibilities and what was expected. And I think that there's more and more that's being expected all the time. Family caregivers often care for people that have been discharged sicker and quicker than they used to be years ago. And I don't know whether about the rest of you, but I work a lot with healthcare systems, including with regards to my own health, and navigating, a healthcare system really takes a lot of time. And we still know that it lacks a lot of care coordination. There's something called the internet. And for many of us who are professionals, people walk into our offices very well intentioned or call us on the phone or over Zoom. And they start by saying, I was reading on the internet and there's a big information overload, but what are the really quality, valuable sources of information out there? And caregivers can feel very overwhelmed by it and trying to sort through it. You have to keep in mind that they now are often expected to manage very difficult medication regimens and sophisticated technology in the home that years ago, that wasn't not expected. And sometimes we think that these people, we label a person as a caregiver. We don't begin to think that they're juggling multiple demands. It's not like they show up and that's the only thing that they've got going on. They're often working part-time or full-time. They may be in the sandwich generation, caring for multiple folks, both children as well as the person impacted by dementia. And as Jean mentioned, and I think is so critically important, they're brokers. They're brokers of a variety of different types of services that are needed. And so important to keep in mind that they often are placed in a situation where they may be doing a lot of the work, but they may not be the ultimate decision maker. I learned early in my career that in working with families, that someone may come and speak with you, and it may have to do with who has the facility of the language, but they may not be that decision maker, and they may in fact be checking with somebody that's not even in this state or in this country who has a lot of input about that. So building that relationship, understanding that that exists, and recognizing the stressors that that person may be experiencing in managing multiple people's opinions about what should be happening. Some people really need to provide and receive caregiving information and support at a distance. And then it's a full-time job almost, locating, accessing, and monitoring quality paid help if you need to have that in your home. So next slide, Zach. So I want to also think about what's been raised by both Elizabeth and Jean, the impact here of what's happening during the COVID-19. And some of this draws from my own work as well as the work of others. We've been running a series of focus groups and interventions during COVID, but this has had a huge impact. Restrictive measures that are led to more and more social isolation. And in this case, I'm going to talk a lot about the family caregiver, but always there is someone they're caring for in this situation. Checkups, services, canceled, postponed, changed, switched around, unavailable, respite. There's wonderful opportunities in our state and other states for consumer-directed care, respite care, where people can work with the Arizona Caregiver Coalition or other organizations to pay a family member or friend to come in if they're on to help them. And it's those things do exist, but other programs that they used to have, like adult day help, maybe attending support groups that give them a break and get input from others. Those things have often had to been postponed or put off. Some of them have been flipped to Zoom and are available now, but there was a whole period of time when we were all trying to catch up with what was going on. Again, even people being discharged sooner and sicker and quicker, given the COVID, up and beyond what we've seen on the daily before this. These home care visits disrupted or discontinued, and really keeping in mind that caregivers may not feel they're getting the kind of preparation and support that they used to when somebody would be able to come in and show some more things hands-on before that. And so lots of expectations from catheter care to tube feeding and the like. Next slide. Also related to this cascade of impact is that it's led to this changes in routine. Not only is there social distancing and self-isolation that just creates some issues associated with loneliness and the like, but it also has limited your access to strategies that manage dementia symptoms. When we were working recently in one of our intervention groups, a woman was describing a situation where just getting out and being able to have her husband have the same kind of daily routine, being with him, interacting, that helped him, in a sense, sleep better, stay on a schedule better, and get out some of his physical activity needs. She saw this great rise in agitation before she started to begin to work with us and us brainstorm other alternatives for her. So many of these tasks become much more harder to accomplish, and there's been a strong evidence that even though there's a greater need for support, there's actually less receipt of support during this time period. I think it's very important, and I know that Elizabeth mentioned this with regards to placement. You all have, I'm sure, seen in the news and the realities of what's happened to the impact of COVID on older adults in long-term care facilities, but caregiving does not end with placement. In fact, it comes with a whole new situations and expectations. And the person that's talking right now, me, my family, my mother has dementia, and she has been moved after my father's death down near my sister, and given my sister's responsibility, we have her in a CCRC there. They're a wonderful organization. But through this, we've really had to do additional advocacy. When we saw UTI emerge, there were just characteristics that were not our mother, even with memory impairment. And how to advocate for that, have things happen during this was very stressful for my sister. And she's my hero. And so it's both impact on the family caregiver and the care recipient as well. Next slide. So what we know from prior research even before this is that many of us who work with family caregivers think of them as the hidden patient. They're at risk for a variety of things, from increased depression, the A word that people don't like to say. It can be really frustrating, and you can increase your anger and stress associated with the kinds of demands and repetitive questioning and behaviors that emerge. Anxiety and worry, feeling like you don't have what it takes to do the next thing. Feelings when you do snap that caregivers are the best at beating themselves up with guilt. And so we have to watch that. And social isolation already exists as their world shrinks more and more. And again, caregivers show up many times with their own physical health problems. And so stress on top of this. Can you just tap the slide one more time, Zach? I think also I want to hit this with more about mortality. Caregiving does not kill. Stress kills. And it's why many of us do what we do, is to help reduce this stress. There's kind of this myth that goes around that caregiving actually kills. It's really the stress associated with caregiving that kills. And I think that's very important for people to take home, because it scares people in some ways to sort of say it the other way around. Next slide. So the CDC and others began to talk about caregiving as a health disparity, on top of the kind of disparities that Jean was talking about, or at least in tandem with them. Yes, they're hidden patients, rarely assessed for their own health issues because they're taking their loved one in to be assessed and ignoring their own. Often not having the energy or the time to go ahead and be engaged in health promoting activities for themselves, so their health continues to decline, and there's significant gaps in the quality of their health and healthcare compared with people that are not in a caregiving role. And so that highlights our needs for caregiving interventions. Next slide. And so what's successful? So work done by my team, as well as many other teams, and Chang most recently in her report, shows that there really is kind of this thread about the importance of teaching people various kinds of skills in combination with other activities. And those skills really are to help do behavior management skills, to manage the behavioral problems that come up, but also to manage your own situation, to change how you think and what you do in the situation, to make sure you also find ways to take care of yourself, to be an effective caregiver, but also to help you maintain your quality of your own life, well as your loved one's life, is important in tandem. Next slide. So I'm going to use, yes, since I have the floor, I'm going to use one of our own evidence-based interventions, and that is the former First Lady who gave the Alzheimer's Association chapter's area agencies on aging and myself an award for work that we did across Arizona and Nevada on CarePro, which teaches people various kinds of skills through group meetings, bringing caregivers together to do mood management, stress management, improve communication with providers, as well as with the person with dementia, to learn how to do better behavioral management of the behavioral problems that emerge, and to engage and stay connected with others through simple, everyday, pleasant events. So next slide. So you don't think that I'm just blowing smoke. I did this for the data geeks in the audience. This is only one of a whole series of positive outcomes we had, reducing depressive symptoms, negative coping, caregiver bother, and the like, and increasing positive things like positive coping, satisfaction with the support we received. And so that happened immediately and after these 10 weeks, but in the next slide, you'll see that it was maintained. Next slide. Maintained over 12 months. So we reduced, for example, here, depressive symptoms from above what is considered the line of depression, down below depression, and maintain that reduction across the next 12 months. Next slide. And so in this pandemic, we were really urged and learned from our focus groups that there were caregivers that were in need, wanted to engage. We'd never done things via Zoom, but we revamped everything. We were encouraged by our community partners and the caregivers to reduce it to 5 weeks with the coach calls in the same week. And so we did that. We've only run our first 4 groups in English and Spanish, 3 in English and 1 in Spanish, and enrolled 32 caregivers with 97% retention. And we've had very positive, similar outcomes with that. Doing that via Zoom and finding new ways to engage people through that. Next slide. And then I want to think for just a moment before I close, I know we're running out of time, that part of what I see as a challenge in our society, and I need all my community partners and policymakers and caregivers, et cetera, to advocate. There are programs, and ours are not the only ones, obviously, that are out there that exist, that can help people at the individual level or interpersonal level. We have a program that works with early stage people and their care partners that's evidence-based, that helps them with care planning and learning some of these skills as well. But also, how do we marry those programs and begin to better embed them, those things that have evidence, and give a menu of choices, because not all things, it's not a one-size-fits-all kind of approach, but how do we marry those with other organizational kinds of intervention levels? So how faith communities can pool resources for education and visitor and respite programs that are done in tandem with what's offered at the individual level. Or the community, how might this education happen in continuous care retirement communities, where we also might embed these for folks that are in assisted living or even in the memory care units to work with programs that we see are effective. And then how do we continue to advocate at the policy level? There's money in the American Rescue Plan for increasing national family caregiver support dollars that come back to the states to support evidence-based programs and the types of work that so many of our wonderful partners do out there, the lifespan respite dollars that need to be there for everything, including folks in this particular population, but also parents caring for children with special needs, for example. Next slide. I want to end with saying we don't pretend to be all things for all people, but we have a line available that people can leave a message or find us on Facebook or email us. We're continuing to provide a variety of different kinds of programs in this, but we also recognize, again, that our programs are not for everybody. And because of that, we have strong relationships with the Alzheimer's Association, DUET, the Area Agencies on Aging, Benavia, a variety out there. Please, I know I probably left people out who are sitting listening to this. I don't mean to, but if you get a hold of us, we're happy to do that. And again, we're providing CarePro Virtual, the early stage partner work. We're working with CarePro for individuals with Down syndrome and intellectual disabilities who develop dementia at an earlier age, and their care partners. We're working with people living alone with memory loss, as well as a CarePro that's offered in long-term for people that have placed their loved ones in long-term care. So feel free to look us up, and we'll do our best to connect you with other resources if you're not interested in the kinds of things that we're offering. And that's, again, not one size fits all, and we are available in English and Spanish. With that, I'll turn it over to Deb as our moderator, and we'll see if there's some questions.
Oh, thank you. We have quite a few questions. We'll try and work our way through them in the time allotted. The first one is anyone working on revising the MMSE so it's more accurate in African-American populations?
You know, I don't know the answer to that. Somebody could be, and I'm not aware of that. But I think that one thing to keep in mind with that, it's a pretty short screening tool, but a lot of times I think healthcare providers will use that in addition to other assessments. So I think that while we wait for a revision of that test or a new screener or cognitive assessment that is more culturally and linguistically diverse, I think it's important that as healthcare providers, we're taking in and taking into account multiple measures. So we're reducing some of that bias by looking at different things instead of just one tool specifically.
Okay, thank you. So the next question is, what are the signs of someone having Alzheimer's versus other dementias? For instance, when someone's losing short-term memory as well as long-established knowledge or losing skills of spelling, etc.
I guess I'll jump in and you all feel free to add to that. You know, there are some really good places, I think, to look for some of this information that can lay it out. There's places like the Alzheimer's Association that has, if you go to their website, it has information about frontotemporal, it has information about vascular, et cetera. And I think that, I know you kind of asked a specific question about what might be going on there. I'm not a physician, I don't play one on TV, and I'm not going to play one here, but what I would say is that, there are differences that can begin to be distinguished. And we have something called the Arizona Alzheimer's Consortium here in the state of Arizona, where there are various sites that you can go to if you're particularly interested in seeing what might be different. For example, frontotemporal dementia happens often at an earlier age. There's often behavioral changes that happen more before the memory changes. And Alzheimer's, typically the memory changes are often the hallmark of that begins. Vascular dementia, if you've had a stroke, there's a lot of confusion that starts out with that. And so it varies a little bit. I know you started, the person that asked the question mixed a variety of things together. It would depend on that timing, et cetera. And I really encourage them to work with a professional. They're very interested in seeing what's going on. But whenever you see a change that concerns you, you ought to speak with a provider and figure out who or where you can go to better understand that. I never encourage people to sort of suffer in silence. And, you know, Jean, Elizabeth, do you want to add to that? That's sort of my first take.
I don't have anything to add. You covered it wonderfully.
Okay, we'll move on to the next one. So this is Johnny Dean, and he says, as an independent dietitian exposed to LTC during COVID, I believe we all deserve medical care for all humans. I got to see high-tech and privileged locations still having the same struggles of increased social isolation during COVID-19 lockdowns to LTC SNFs. And it seems that despite the discrimination, there were little benefits to increase bottom line quality of life that all suffered to what medical care was available during 2020. So this may be annotated, but over a large region in Texas, the consistent treatment course that patients chose among their facilities were to opt out of treatment and to go into hospice. And it was difficult to feed someone to want to live life when they've become caged in rooms without the surrealism of an existential crisis. So the question is, can I have your thoughts on patient rights when government intervenes, when it interrupts fragile care plans to sustain QOL? And then thank you for all of you guys on this help talk. Does anyone want to tackle that?
I can start. I think that's a complex ethical kind of question. It's a why question because there's a lot of debate about when to intervene and tell someone what they need versus giving them the right to do some self-advocacy. And I think a lot of that probably goes in that complex problem of fatalism too. I mean, why do anything? If this is what it's going to end up like, then I just go into hospice. I just take this as I die. And what's that happens a lot. Like I tried to point out with some of these diverse communities, they just give up. It's just too hard to get what you need, so you give up. While some other cultures would, the dominant culture would keep, I see them being more persistent, hanging in there, trying to find the answer. An example would be the lady that's on Fox News. Her in-laws died, and now she's ready to sue the governor, you know. But you won't find that happening with other groups. And there are a lot of questions ethically about how much involvement the government should have, even as I keep trying to point out, mandating, you know, even COVID shots and things like that. Who's in charge of that and who tells you what to do with your life? So ethical things, hard, wicked problems. That's all I need to say. I can say about that. Anybody want to add?
Elizabeth or David, do you have any additions to that? Okay. So another question, is hypertension linked to dementias?
You know, I looked that one up while I saw that, and Liz probably could answer more about that. But hypertension and cognitive problems are related. And just as a public service announcement, I wanted to tell everyone as well that hearing problems are as well. So make sure you're checking in on your hearing, because now there are a lot of studies that are showing that hearing is related to dementias as well. So it's our health, it's our biology. We all know we need to take care of ourselves. And if you're not getting the care that you need, then it can lead to these types of things.
I'd only have one statement. Heart health is brain health. Heart health is brain health.
Thank you. So we're running out of time here. I won't be able to address the other questions. There's some great ones. We will thank you all for putting those into the chat. We encourage you to follow the College of Health Solutions on social media. You can see the social media channels on the screen so that you can learn more about other opportunities like this one. Our next Health Talk webinar is Tackling COVID-19 Health Disparities, the Role of Community Health Workers. And this will take place Thursday, June 17th at the same time. There will be a little bit of a hiatus here. Registration will be open soon. And again, that's available at asuhealthtalks.com. Thank you again to all of our attendees and of course to our excellent speakers today, and everybody have a great rest of your day.